So I just quickly cobbled together this lecture to make a few points a little clear. There is actually no option to femtolaser assisted cataract surgery. If everybody in this room, if there are 40 people, and if a femtolaser cost 5 lakhs, everyone would have bought one. There would be no debate. It's like moxifloxacin versus other antibiotics. There's no contest. But the fact of the matter is that it costs 2 crores, 3 crores, 4 crores. We live in a country where people cannot afford, and many a times, basically, they don't want to spend either, even if they can afford. So it is our job to educate them that this is better technology, this is the future, and how we should go ahead. Let's go through some clinical advantages of laser cataract surgery. First of all, if all of us remember 20 or 25 years ago, phacoemulsification arrived on the scene and was an unstable procedure. Good ECC surgeons were better with ECC than with phaco, and that's because there was no capsular rhexis. So 80% of the game changed when Neuhann and others pioneered capsular rhexis, and the big word that on the dining table at night was Howard Gimbel and Thomas Neuhann. And Dr. Haldipurkar will remember those days. And capsular rhexis changed everything. So if you have a really good rhexis, phaco becomes easy after that. If your rhexis is bad, you had it. All of us know that in every case, you cannot get a perfect rhexis with manual capsular rhexis, no matter how skilled a surgeon you are, and that's the fact of the matter. Remember that a machine will do 100 out of 100 times will give you a perfect capsular rhexis, because machine never gets tired, machine never fights with his wife in the morning, and other things, and there are other factors, and machine is not interrupted by loud sounds in the OT or things like that. So, of course, lens fragmentation is part of all femtosecond laser cataract surgery. This is basically a catalyst presentation which applies to every femtosecond laser system, whether it is LensX or Victus. That a lot of the studies that my young colleague has mentioned are Americans dealing with grade 2 cataracts, and they weren't very good dealing with them even with manual cataract surgery. So if they're having problems docking patients, etc., it's because they really don't know what they're doing. Once you learn how to use the femtolaser, it's very, very reproducible, just like driving a car or using your mobile phone. I was coming from the airport last night at about 10:30, and there was a little issue with the taxi. So we got a cab, and I told that guy, Brilliant Convention Center. I asked him, "Tumko malum hai kidhar hai?" So he says, "Haan, mereko malum hai." So after he sets off, about 2 minutes down the road, he's shouting in the phone something. Says, "Kya kar raha hai?" So he says, "Well, Google Map." So he didn't know exactly how to do it, and he kept saying Bridgin Convention Center, and the Google Map just went haywire, and it kept saying, "Please repeat again, please repeat again." So there's no point having technology that you don't know how to use. If so, I had to do it on my phone. This is a true story, and then direct him, because poor guy had absolutely no clue what was going on. So the issue is that the technology works great. You have to be taught how to use the technology. You can do cataracts like this and have clear corneas the next day, which is absolutely impossible with manual phaco. Let's have a look at this case. I know it's a debate, but this will make it very, very nice and simple. This is wonderful manual cataract surgery, and this is me doing it. And we inflated the eye with viscoat, etc., etc. The minute you touch it, that's it. So this never happened. You had it. There was no way to prevent this. Absolutely no way out. Of course, I managed and I put in a multifocal lens and things like that. But this could have, if this was a hard cataract, this would have gone straight down. Let's have a look.
Sir, Cyres, we are, I think, running behind.
Yeah, I'll just come. This is the answer. Same kind of intumescent cataract with same kind of intumescent cataract with femto-Lasik, femto cataract surgery. You can look one shot and you will get it. You will have to go to Argentina to see an Argentinian flag, because you won't get any more in India. Subluxated lenses as well. It's pretty simple. A case like this would be hard as hell trying to do it manually. We can just decenter the capsular rhexis, and in one pass you will get a perfect rhexis like this. I'll just speed it up, and
yeah,
that's it.
That's it. No,
Yeah.
but with short time, you really,
So that's
came
what it
out with
looks
a
like. You
beautiful
never
thing.
get it manual. So as I was just summing up, that basically our issue with femto laser cataract surgery is it's expensive, it's expensive, it's expensive. If it was cheap, all of us would be doing it. It wouldn't be a debate topic.
Yes, I fully agree with you. Anyone from the audience would say, yeah, for or against the femto for cataract? Those for femto, please raise your hands. Even if you have not bought it.
Imagine you're getting it for free.
Yeah, get it for free. And I presume those who have not raised their hands are against it. Or some of you are not decided. Those not for femto, please raise. It's see.
I absolutely
again,
agree.
That's
I absolutely agree with you.
Technology evolving, but even today as it exists, I don't have one. It definitely has a role in select cases. It's beautiful. There's no question about it. Thank you so much, Cyrus, and you go
Thank
to the
you.
next.
So this is the next talk where Gaurav is my next victim, and immediate bilateral sequential cataract surgery for presbyopia and hyperopes. I got the title wrong. I just did it again. Okay. So, I'll just quick. How many minutes is it?
3 minutes.
So the basic issue is that no one wants to grow old anymore and no one wants to wear glasses anymore, which is why it's become so fashionable for us to do the multifocal lens implants. This old guy here was reported in Google. He was 90, and before he died, he wanted to drive a Lamborghini, so he bought one. And we all know Hugh Hefner. So the best vision is within your reach with a extended depth of focus lens or a trifocal lens. And this is what I'm basically doing, either putting in EDOF lenses or trifocal lenses. The caveat is that you must have optical biometry. If you're using that old thing with that axial thing, I've just thrown it away, so I don't know what it's called anymore. You have to use optical biometry. The days of the old biometry are over. If the patient wants multifocal lenses, they must have immediate sequential bilateral cataract surgery. And we use a markerless system to provide those kinds of outcomes. So I'll just run through that.
No, but actually the procedure need not be shown in a debate.
Yeah, so this is
just
how
have
it
to
is,
talk on
and
the
that's why it's so accurate, etc. And so now coming to that, what Gaurav is saying. So even in 2002, before the lenses were good and developed, LASIK, laser vision correction for presbyopia, even then multifocals were better than LASIK, and this was the editorial in JCRS, and it says that multifocal lenses for presbyopia is the future. So presbyopic LASIK is basically monovision with different brand names, and the problem with monovision is those who have had it, you have depth perception and other issues where you can't drive properly. So new versions of LASIK monovision have come out with different names of Presby, that, beyond something, Supracor, whatever. All basically when you put that patient on the auto ref, one eye is minus 0.5 and the other eye is minus 1.5. It's basically monovision with different names. The whole idea of creating aberrations on the cornea to increase the depth of focus is flawed because the cornea is a monofocal structure and the lens is a multifocal structure, and that's why we better tackle the lens and not the cornea. Correcting presbyopia with a lens is simpler, cheaper, and permanent. No need to buy excimer, no LASIK touch-up every 3-4 years, no flap complication, no epithelial ingrowth, and all of us are cataract surgeons, and all of us can do this very easily. The most damning indictment of LASIK for presbyopia came from John Marshall and David O'Brat, who've been doing LASIK for 20-25 years, and are big researchers. They wrote there, the changes within the first 5 years after doing LASIK for presbyopia were higher, double than what expected physiologically. And the result, presbyopia is the result of physiologic cilio-zonular lenticular changes rather than regression of correction at the level of the cornea. So it's not that the LASIK changes, the LASIK regresses, it's the very fact that the eye responds to that and increases its rate of presbyopia by double. So it's a failed procedure. Basically, you have to implant lenses. Another very good study said the mean regression at 1.5% in 3 years. So in 3 years, you have to do the procedure again. Thomas Conan said that you have to use multifocal IOLs to correct presbyopia, and Lasik is not a worthwhile option. So that's all I could fit into 3 minutes. Thank you.
Beautiful.